about added value of PET-CT in patients with cancer of unknown primary. Cancer of unknown primary is defined as pathologically confirmed metastasis in the absence of identifiable primary tumor despite a standardized diagnostic approach. It accounts for 3 to 5% of all cancer cases worldwide. The management of patients with malignant disease depend on identification of the primary tumor, so its absence has significant diagnostic and therapeutic problems. Only 20 to 27% of primary sites are identified by conventional anatomic diagnostic modalities in cancer of unknown. To date, PET has been demonstrated to be the most efficient method to localize the primary lesion in patients with cancer of unknown primary, with detection rate between 24 and 53%. And the indication for PET in patients with cancer of unknown primary is graded 1A according to the German Consensus Conference. Grade 1A indicates scientifically proved benefit and an established clinical use. The main limitation of PET relates to its limited anatomic information, and frequently cell tracer accumulation cannot be precisely pinpointed. In such cases, a combined functional PET imaging with a high spatial resolution morphologic display, such as CT or MRI, would be desirable. And the main advantage of combined PET-CT imaging is its ability to correlate the abnormal metabolic changes detected on the PET study to the anatomic structures defined as the CT imaging in a very accurate manner. Several studies have evaluated the accuracy of PET-CT versus that of PET alone. And again, indefinitive diagnosis ranging between 20 and 40% by using integrated PET-CT is commonly reported. In patients with cancer of unknown primary, similar benefits could be expected by using PET-CT instead of PET alone. We planned our study to evaluate the added value of PET-CT imaging in the detection of primary tumor in patients with cancer of unknown primary. Patient and methods. The study included 45 consecutive patients presenting with histologically proven metastasis from unknown primary site who underwent PET-CT scans between June 04 and December 07 at St. Louis University Hospital, St. Louis, Missouri, United States. The patients consisted of 33 males and 12 females. Their age ranged from 40 to 82 years. Excluded from this study patients who presented with biopsy-proven cancer from unknown primary site and started treatment before PET-CT study. All cases were unsuccessfully studied for a primary cancer before the PET-CT scan with physical exam, lab tests, and conventional diagnostic procedure. PET-CT scanning, patient preparation. Patients fasted at least 4 hours before the tracer injection. Intravenous injection of approximately 0.14 millicure per kg of FDG with a maximum dose of 14 millicurie. Blood glucose level was measured immediately prior to FDG injection and was less than 200. Patients were instructed to sit in a quiet injection room without talking during the subsequent 45 to 60 minutes of FDG uptake phase and were allowed to breathe normally during image acquisition. PET-CT scans were acquired using 2 different PET-CT scanners from Philips Medical System Gemini in 30 patients and Gemini TF in the remaining 15. This is the Gemini TF PET-CT. It's a high performance time of flight capable fully 3-dimensional PET scanner with a 64 slice brilliance. CT acquisition was performed before emission acquisition, and it is a low dose CT scan non-contrast used for image fusion and attenuation correction. Emission scans were acquired at 1 to 3 minutes per bed position dependent on the body mass index. The 3D true whole body acquisition parameter consists of 128 by 128 matrix, an 18 centimeter field of view with 50% overlap for 18 to 22 bed position. Image analysis. True whole body PET-CT images were retrospectively evaluated in a Gemini TF extended brilliance workstation by 2 nuclear medicine physicians, and a log was kept to record cases of lesions suspicious for primary tumors. These suspicious lesions were verified by correlation with all available clinical, pathological, and follow-up information. Patients were categorized into two groups. Group 1, those presented with cervical metastasis, include 15 patients, and Group 2, those presented with extracervical metastasis, including supraclavicular lymph nodes, and included 30 patients. Results. Presenting site. A total of 16 cases were presented by lymph node metastasis, 12 with liver, and 6 with soft tissue, 5 with brain mets, and 4 with bone mets, and 1 with peritoneal fluid, and 1 from pleural effusion. According to the histopathology, a total of 36% of metastases were from carcinoma, 31% were from adenocarcinoma, 24% were from squamous cell carcinoma, and 9% were from poorly differentiated malignant nucleus. This CT scan suggested a primary tumor site in 29 of the 45 patients. 5 cases were false positive, and in 24, a primary lesion was confirmed. Of these 24 patients, 8 had cancer of the tonsil, 7 had lung cancer, 2 had cholangiocarcinoma, 2 had base of the tongue cancer, 5 had one in each of the following: pancreatic cancer, prostatic cancer, laryngeal cancer, colon cancer, and lymphoma. We assume that when PET-CT was negative, and during the follow-up period and with use of other conventional imaging modalities, there is no primary confirmed, we assume that the results of PET-CT is true negative. In order to calculate the sensitivity, specificity, accuracy, positive predictive value, and negative predictive value. The overall sensitivity was 89%, specificity 72%, accuracy 82%, positive predictive value 83%, negative predictive value 81%. The patient in group 1 had a higher sensitivity, specificity, and over accuracy in comparison to group. According to the pathology, the high sensitivity, specificity, and accuracy was reported with poorly differentiated malignant neoplasm, in which all cases are actually detected by the PET-CT, followed by squamous cell. Comparison of the SUV max between different types of histopathology in the 24 patients showed that poorly differentiated malignant neoplasm has the highest SUV max, followed by the carcinoma and then adenocarcinoma, and last case number 1. A 57-year-old male presented with a mass in the right hepatic lobe, and a 4-phase CT scan of the abdomen showed a large liver right lobe mass, suspicious for hypovascular hepatocellular carcinoma. Liver biopsy showed a poorly differentiated carcinoma with neuroendocrine features. Upper GIT endoscopy and endoscopic ultrasound was normal. Colonoscopy and biopsy showed a benign polyp. A whole body PET-CT scan showed bilateral FGG avid hepatic lobe lesions disseminated FGG avid bone lesions, a focus of intense tracer uptake in the prostate, suspicious for prostatic primary. We repeat the PSA, and it was negative, was a normal level. Tissue sampling of the prostatic lesion confirmed extrapulmonary small cell carcinoma with neuroendocrine features. 51-year-old male presented with right neck mass. Biopsy showed a squamous cell carcinoma. A CT scan of the neck done prior to the biopsy showed a mixed attenuation cystic solid mass in the right jugular chain without evidence of a primary. Neck MRI showed only the neck mass without evidence of. A whole body CT scan showed a very intense FGG uptake in the right tonsil region. In addition to the FGG avid complex cystic mass in the right neck, and subsequent right tonsillar biopsy showed squamous cell carcinoma. 49 years old male patient who was referred for PET CT scan to look for a primary tumor after a metastatic adenocarcinoma was biopsied from the brain. This is the transaxial sections of the CT scan of the chest showed normal finding with no evidence of lung. Maximum intensity projection image of a whole body scan showed multiple foci of intense uptake in the right upper mediastinum and right lower lung loop with SUV max 8.7 and tense dorsal vertebra. Suggesting the lung primary, and also in the bunny bill. A transaxial section of whole body PET CT scan showed an intense FGG uptake in the right lower lung with no corresponding CT abnormality, and a primary adenocarcinoma of the right lower lung with brain and bone metastasis was confirmed. Conclusion: we conclude that whole body PET CT detected a primary tumor in 53.3% of the 45 studied patients with cancer of unknown primary. PET CT provided detection rates higher than that reported for any other imaging modality. Therefore, PET CT should be considered as a standard of care imaging in all cancer of unknown primary cases. Thank you.